So many kids.
Hi, good morning. Is everyone here?
Good morning, Doctor. Let me check.
Everyone here? If everyone's here, then just start.
Just a moment. Okay. Go to it. Okay. I think I can start.
The first one, right?
Yeah. Assalamualaikum and good morning to everyone. Okay. Today I will be presenting procedures supervised by Dr. Chan. So these are the contents of our presentation today. First procedure will be ABG and VBG. The next one is capillary blood gas, central venous line insertion, and urine culture and sensitivity. Okay, so I will present the first topic, arterial blood gas and also venous blood gas. So an arterial blood sample is collected from an artery primarily to determine the arterial blood gas. So the sample for ABG is the blood from the artery. So the purpose of ABG is to measure the oxygen tension or PaO2, the carbon dioxide tension, PaCO2, the acidity as indicated by the pH value of the blood, oxyhemoglobin saturation, SaO2, and also the bicarbonate level. An arterial blood sample is obtained either through a catheter placed in an artery or using a needle and syringe to puncture an artery. So the commonly used puncture site for the collection of arterial blood sample is the radial artery. If radial artery is not possible to be used, then an alternative include the posterior tibial, dorsalis pedis, brachial, and or the femoral artery. The indication to perform ABG is to evaluate there is any acid-base disturbances, to measure the partial pressure of oxygen and also carbon dioxide, and detection of quantification of the level of abnormal hemoglobin, such as carboxyhemoglobin or the net hemoglobin. The contraindications of this test, when there is an abnormal modified Allen test. Modified Allen test is a test to assess the collateral circulation of the hand. So when this test is abnormal, means that we cannot perform arterial blood sampling on the hand. We can either use the alternative or use the other hand. And then when there is local infection, so cannot puncture the skin. Local infection, there is severe peripheral vascular disease or the artery selected for sampling. The common complications associated with arterial blood sampling will include the local pain at the site of injection and paresthesia, bruising, and also minor bleeding. A less common complication associated with arterial blood sampling would include the local hematoma, infection at the puncture site, air or thrombus embolism, local nerve injury when the needle accidentally punctured the nerve, and arterial occlusion from the hematoma. So the equipments that are needed to perform this procedure will include the non-sterile gloves, antiseptic skin solution, needle size 27 or 25 gauge, catheter size 24 or 22, or butterfly needle connected to a tube. Then we have a nice blood gas syringe, 2x2 sterile gauze or cotton ball to stop the bleeding, tape, and also sharpening. The methods on how to perform: firstly, approach patient and also the caretakers, introduce, gain consent, explain procedure, and also position the patient. Gather all equipments and make sure that all are functioning. Perform modified Allen test to see whether the hand is fit to be used for arterial puncture. Palpate the radial artery to identify the ideal site for the puncture, and then clean it with an alcohol wipe for 30 seconds and allow it to dry. A topical anesthesia may be applied prior to the procedure, and then hold the patient's wrist in an extended position by approximately about 20 to 30-degree angle, and then hold the ABD syringe like a dart, and then insert the needle through the skin at an angle of 30 to 45 degrees. And then continue advancing the needle until you see a flashback of that to the syringe, and that means that you have punctured the artery, and the ABD syringe should then begin to self-fill in a versatile manner because of the high pressure in the artery. Then after collecting enough sample, remove the needle carefully and apply immediate pressure over the puncture site with some gauze or cotton ball. Then remove the ABG needle from syringe and discard it immediately into a sharp bin. Expel any air from the sample is present and cap the syringe, and the blood sample is already can be taken already to be analyzed for ABG. So this is the video.
Actually, the audio is something wrong, is it?
Yes, I think everyone couldn't hear it. Not sure why.
Azri cannot. Get it?
The fingers may blanch because of the interrupted blood supply. Release the ulnar artery while the extremity must be assessed for collateral circulation by utilizing the Allen test prior to an arterial
Cannot.
puncture. To perform the Allen test, elevate the
Everybody can hear or not? Can ah?
Yes, doctor.
Can, doctor.
Okay.
infant's hand and simultaneously occlude the ulnar and radial arteries at the level of the wrist. The goal is to temporarily impede blood flow. The fingers may blanch because of the interrupted blood supply. Release the ulnar artery while occluding the radial artery and observe for color change. Do not puncture the artery if reperfusion exceeds 10 seconds. Delayed reperfusion indicates inadequate collateral circulation. A modified Allen's test should be conducted on the posterior tibial artery and the dorsalis pedis artery to assess for collateral circulation before a lower extremity arterial puncture is performed. The wrist is stabilized and placed in the neutral supine position. Be careful not to hyperextend the wrist, as this may occlude the vessel. Cleanse the insertion site and the surrounding tissue. Puncture the skin and penetrate the artery at a 15 to 25 degree angle with the bevel down, or puncture the skin and penetrate the artery at a 30 to 45 degree angle with the bevel up. The shallow approach is recommended in the preterm infant. If the initial puncture does not yield any blood, palpate the artery above the insertion site. Be careful not to contaminate the insertion site. Adjust the angle of the blood collection set until blood flow is achieved. Leave the end of the blood collection set open to air until blood is identified. Then place a syringe on the open end of the collection set and gently aspirate the required volume of blood. The infant's identity was assessed by utilizing 2 of the approved JACO identifiers, and blood collection necessity was confirmed with the medical provider. In addition, oral sucrose was administered 2 minutes prior to initiating this video recording and administered intermittently for continuous pain control during this minor procedure. When the blood collection is completed, remove the collection set while simultaneously compressing the insertion site with sterile gauze until hemostasis is achieved. Be certain to assess for appropriate peripheral blood flow at the completion of the procedure. Peripheral arteries can be located by palpation or transillumination. The palpation method was demonstrated in this video.
So make sure after you puncture, especially for babies, make sure after you puncture the arteries, right, you check the perfusion of the fingers, okay? As the younger they are, the more dangerous it is, right? Not without consequences. Also, if the child is septic, and if the child is septic and you're in the ICU, children who are septic, usually their circulatory system doesn't work very well, so isn't it? Right? Children who are septic who are on inotropes, also you have to be very careful when you puncture the arteries. But if you if you don't do the Allen test, you cut off circulation, that's it, gangrenous. Okay? Sometimes cannot help it because you sometimes you have to puncture because the information that you need from the arterial blood gas, you need it for your ventilation or whatever it is. You have to be very careful, especially in an ICU situation. Okay, done. Azri, now you share back. Stop sharing. Stop sharing. Okay. Am I the only one who cannot hear Azri?
We cannot hear you, Azri.
Hello. Signal. Hello.
Azri, tak dengar lah, kuat sikit.
Hello.
Okay.
Okay. Okay, the next is VBG. It is an alternative for ABG in estimating systemic carbon dioxide and also the pH of the blood. And this procedure is more convenient in ICU emergency, in which venous blood can be quickly and easily obtained. Because usually in this setting, there is already an indwelling catheter in either the central or the venous vein, peripheral vein. So the sampling site for venous blood sampling, for peripheral venous sample, we can obtain from venipuncture. For central venous sample, we can obtain from the central venous catheter. So complication associated with this procedure mainly result from the puncture itself, which is hematoma or bleeding, nerve damage, extravasation injury, arterial puncture, infection, and also thrombus formation. The equipments that are needed for this procedure include glove, alcohol swab, tourniquet, topical anesthetic, and catheter, and also needle. Okay. So the methods of how to perform this, after approaching patient, introduce, gain consent, and also position the patient, we identify a suitable vein for the venipuncture. Usually for neonates and infant, we use the dorsum of the hand, and for older children, we use the antecubital fossa, just like in the adults. And we secure the limb by holding the joint above and below the side and apply the tourniquet. And just like ABG, we may use topical anesthetic prior to the procedure. Clean the skin with an alcohol swab. We puncture the skin and advance the needle at 15 to 30 degree angle. And we start collect the blood when we see flashback of blood in the syringe. And once we obtain adequate amount of blood, we remove the needle carefully and apply pressure on the site to stop the bleeding. Let me try again.
Oh, here it goes. This is gonna be so cool. You're being so brave. I'm gonna show this to your brother and sister, okay? And Dad.
That's normal.
It is such a tiny needle, huh? It's like a baby needle.
2, 3, slow. That's it. That's as far as it goes. It didn't go very
Look
far.
at your blood going in.
You did fantastic, by the way. I thought you might flinch, but you didn't. Okay, I just guess how much this holds. This only holds a teaspoon. Only holds 5 milliliters. Once I get to that 5, we stop.
Your blood is so dark, Micah.
I'm gonna take this off so the pressure goes back. Wanna know why it's so dark? It's already dropped off the oxygen. It's going back for more. Okay, I'll count to 3. 1, 2, and 3.
You did it!
Okay, so that is all for my part.
So we continue the capillary blood gas sampling. My name is Iman Fikran, Rosli. Continue. So what is blood capillary gas sampling? So it is a process of puncturing and collecting capillary blood samples in infants. It is essentially the function is the same as arterial blood gas, as mentioned by Brother Azri, which allows us to analyze the neonate's ventilatory status um, by, uh, by the adequacy of the ventilation by PaCO2, as well as to estimate the acid-base balance or pH in infants or neonates. Continue. So this is the indication as well as contraindication of capillary blood gas sampling. So firstly, it is indicate in so arterial blood gas analysis is indicated, but arterial access is not available. So case second is when we do history of physical assessment, there is a change in the patient's status. Next is abnormal non-invasive monitoring readings, for example, transcutaneous values, end-tidals CO2 as well as pulse asymmetry. And lastly is indicated in the assessment of initiation, administration, or change in the therapeutic modalities. For example, when we want to use mechanical ventilation in the patient when it is indicated. Next is the contraindication of capillary blood gas sampling. So firstly, it is contraindicated in patient less than 24 hours old, where the patient usually have poor peripheral perfusion. Next is the site location that not to be used for capillary blood sampling. Firstly is area of infection, cyanotic or poorly perfused heel, fingers of neonates, inflamed, swollen, or erythematous tissue, as well as previous punctured site. And lastly is it is contraindicated when direct analysis of arterial blood is needed for an accurate PaCO2 reading. Let's continue. So next is the complication of capillary blood glucose. Capillary blood sampling, sorry. So it's firstly complicated with infection, where it can can cause cellulitis or osteomyelitis when the punctured site happen to be at the posterior side of the heel, where the calcaneum is located. Nextly is the collapse of the veins if the tibial artery is lacerated from the puncturing the medial aspect of the heel. Next will be the nerve damage if the fingers of the neonates are punctured. Hematoma also can happen, scarring from the puncturing site, as well as localized or generalized necrosis, which is a long-term effect. So continue. So this is the list of equipments that is needed for the capillary blood sampling. Firstly is Lancer or heel prick devices. Next is capillary collection tubes. It is usually heparinized to avoid clotting of the blood itself. So alcohol swab for the puncturing at the site of for the capillary blood sampling, and lastly cotton gauze and tape for post collection. So continue. So where we want to puncture the site for the capillary blood sampling. So firstly, it is usually done at a highly vascularized area, such as the heel or the fingers. So the site heel is usually done for the age from birth until 6 months. Usually weighs from 3 to 10 kilogram, and the placement of the lancet for the puncturing site is on the medial or lateral aspect plantar surface of the heel. Next is finger. Finger is usually done in a patient more than 6 months old and more than 10 kilogram. and it is usually done on the third or fourth finger on each on the side of the ball of the finger perpendicular to the lines of the fingerprint. So right here and right here. So continue. So the methodology of capillary blood gases sampling. So firstly, you must again to identify the patient's identification. So next is you want to explain the procedure to the parents as well as to gain their consent. And we must wear appropriate PPE. So I forgot to mention in the equipment, you must also have a non-sterilized glove for our personal protection. So for a poorly perfused heel, so we must warm with gauze in warm water, in which to promote blood flow to the area. Next is we want to clean the skin with an alcohol swab to sterilize the area and start with a sterilized lancet in a depth of 2.5 millimeter or less. Then we withdraw the blood from the site. Let's continue. Next, we must discard the first drop of blood. We must wipe it with a gauze because you want to take the next sample. Next, you must intermittently squeeze the heel gently, not forcefully, not squeezing it too hard. When the heel is reperfused until sufficient blood is collected within the hyperonized capillary tube. Next, we must seal the capillary tube itself from end to end, and then we must set it to the blood gas analyzer for the analysis of the blood. And as for the site of the puncture, we must apply pressure to the puncture site, and then we seal it with dry gauze and tape. So continue. This is just a summary of what I've said before. Continue. And this is a video.
This is an instructional video about how to collect a capillary sample from a neonate. When sampling, be sure to always follow your hospital's procedures. Before sampling, confirm the patient's identity. Make sure there is good blood flow to the sampling site. Disinfect the puncture area. Make an incision of maximum 2 millimeters depth on the plantar surface of the heel. Wipe off the first drop of blood. Hold one end of the capillary tube horizontally into the forming blood drops, filling the tube and keeping air out. If blood is not forming freely, very gently squeeze the lower leg and ankle. Carefully seal the incision site. Mix the sample thoroughly by inverting it slowly. Using a magnet enhances the mixing. Label the capillary tube with patient ID and immediately transport the sample to the blood gas analyzer.
So that's all from this part of the presentation.
Okay, next.
Alright. Can you hear me? Nah. Sekejap. Dengar tak?
Yes.
Alright, okay. Okay, good morning, doctor and everyone. So I proceed the presentation with central venous line insertion. My name is Sharifah Haja. I will proceed the presentation. Okay, next. Alright, so what is central venous line? It is placement of device such as catheter into the central venous vessel that allow access to the bloodstream. So it is inserted until the terminal lumen resides within the inferior vena cava, superior vena cava, or right atrium. It is essential in anesthesia for major surgical procedure, for treatment in ICU, and also nutrition, administration of enteral malnutrition, and administration of drug in patient with enteral malnutrition or malignancy. Okay, so as you can see in the picture, there are some placement sites for the central venous line. So the most common insertion site are femoral vein, internal jugular vein, subclavian vein, and also umbilical vein. So in emergency situation, the femoral vein is most frequently used because it is relatively easy to access and it is distant from the major site for resuscitation. All right. And then, however, it is less desirable outside the emergency setting because it is not suitable for long-term access in mobile patient. Okay. And then okay. For neonates younger than 10 days of age, umbilical vein or artery catheterization is preferred site. Okay, next. Okay, so okay, next is type of central venous sign. So there is tunnel and non-tunnel. So tunnel central venous catheter is placed under the skin. It means it can be used for a longer duration of time. And non-tunnel is designed for temporary and may put into a large vein at the neck or chest or groin. Okay, and then there is also peripherally inserted central catheter, PICC. It is just extension from their peripheral insertion site until the catheter tip lies either in the distal third of the superior vena cava or at the cavo-atrial junction. So the advantage in children that they may be inserted and removed without a general anesthetic in some children and have lowest complication rate of central venous access device. Okay, so the duration can be between 10 days to 2 months. And then it can be placed for weeks or months. It is usually used in patients who need to extend it medication. It can also be used in chemotherapy. Okay, lastly is implantable port. It is most useful for children that requiring intermittent venous access over a long period of time. Such conditions include chronic diseases such as frequent exacerbation, like in cystic fibrosis, and also intermittent chemotherapy. So it allows patients to bath and swim, require less maintenance, and has fewer adverse body image consideration. All right, next. Okay, so these are the indication and contraindication. It is indicated in severely ill ventilated pediatric patient with difficult peripheral vein access, and when we want to obtain central venous pressure, and it can give a longer term intravenous infusion in patient in hemodialysis, in patient that need frequent blood draw, and for infusion of large volume of irritating substance. And it is contraindicated if there is no trained doctor for this procedure. And then if the patient has bleeding and clotting disorder and risk of contamination, severe abdominal trauma for femoral vein cannulation. And then if patient has skin lesion and known thrombosis of the vessel. Okay, next. This is the equipment, sterile set. As you can see at the lower picture. And then lidocaine, 1% for local anesthetic, 2 ml syringe, 23 gauge needle, and then normal saline, and then Seldinger cannulation set. As you can see in the picture, like yang 3 lumen catheter, that is catheter, And then there is a guide wire, like the wire yang in the loop.
The one, the loop is the guide wire. So the one with the smaller loop, that's the guide wire. So the blue tip is the covering actually. So once you have the cannula inserted, this blue tip you take off and then you put it through the cannula and then you guide the guide wire through. Then after that, what will happen is that you pull this plastic loop of the guide wire, you pull out, obviously leave the guide wire out. Don't go and you must always hold on to the end of the guide wire. Don't let it go into the patient. And then what you do is you guide the catheter onto the guide wire and slowly push the catheter in while pulling out the guide wire. Okay?
All right, thank you, Doctor. So it explains in the next slide. Okay, so this is called as Sardinger technique. Okay, so first we insert the needle that attached to a syringe, inserted into the vein. This is important because we need to puncture the skin first, and then to identify the vein, so we can see the backflow of the blood. And then the syringe is removed, so the flexible end of guide wire is inserted through the needle into the vessel. And then the needle is removed, so leaving the guide wire in place. And then the catheter is advanced with twisting motion over the guide wire. And then the guide wire is then removed as the catheter is held in place. So the guide wire is used to guide the catheter inside the vein. So the last thing, the catheter should flush easily with fluid. All right, so this you can see after this in video. Okay, next. Okay, this is more specific. I mean, this is in ventilated. For ventilated child, we give dose of analgesia and sedation. So it is almost same as what I said before. So in supine position, we need to expose the chosen leg and groin in slightly abducted position, and then identify the landmark first by palpating the femoral artery pulse. So the vein is beside medial to the femoral artery. Okay, and then clean the inguinal region using the iodine and 70% alcohol, and then infiltrate local lidocaine to the proper site of skin incision, and then insert the saline syringe, and then pull the plunger gently and advance superiorly. Okay, next. So then, when there is, this is same like what I said before, there is a backflow of the blood. So disconnect the syringe from middle and then insert the guide wire. And then withdraw the needle and then insert the cannula over the guide wire and then remove the guide wire. Okay, and then we need to check the easy backflow by suction of the syringe and flush with normal saline. Right, and lastly, secure the line using sterile dressing. All right, so this is the video. So first they clean the side. Okay, and then put the sterile drape. Then these are the equipment. Not the monitor. Alright, so first they insert the needle and watch for backflow. After that, disconnect the syringe from needle and then insert the guide wire. And then withdraw the needle. And then insert the dilator. So the doctor use scalpel to open up the skin. Then insert the line. So you can see there is backflow. Right. So they infuse a normal saline to check the flush and to do flush. Alright, so lastly they secure the line and then they so they secure the line and then using sterile dressing. Next, secret. Okay, so next, so for the complication, during the catheter placement, there is can be risk of bleeding, local hematoma, bowel or bladder perforation in femoral, and then pneumothorax, commonly in subclavian site, and then malposition, air embolism. Air embolism more common in cannulation of subclavian or interjugular vein. Okay, so guide wire or catheter fragment embolus can be avoided through the application of a very meticulous technique. And then with catheter in place, there is risk of infection, CRBSI, catheter-related bloodstream infection. And then there is risk of swelling over the lower extremity resulting from impact venous return. The swelling can often be managed by elevating the leg and should be taken care should be taken to confirm palpable distal pulses in this patient. Okay, and then there is risk of deep venous thrombosis or inferior vena cava thrombosis, catheter knotting, catheter malposition, catheter venous central venous catheter. It can trigger thrombosis because of the vessel wall damage at the insertion site. The obstruction of the flow can cause stasis, irritation of the vessel, and then the can cause because of the presence of foreign substance in the vessel. Okay. All right. I think that's all for central venous sign session. Thank you.
Okay, good morning. My name is Uzma. I'm gonna present about the urine sampling for culture and sensitivity. Okay, next. Okay, just a brief introduction. So, culture is the method of multiplying microorganisms by letting them produce in predetermined culture media. So we can determine the type of microorganism using culture, and for sensitivity, we can check the effectiveness of a drug against a certain microorganism to select the best effective drug. Okay. Next. All right. So for the indications, so first, if there is children that we suspect that have UTI and we want to diagnose and also give we want to guide for the microbial therapy. And then secondly, work up in patients with isolated fever or altered mental status. Next is part of sepsis evaluation when we don't know what is the clear source of the sepsis. All right, next. Okay, so for the equipments, here are just like some of the equipments, but it depends on the method that you're using. So generally for all, we use gloves, and we also need sterile container and antiseptic solution. And then if we do catheterization, we need a sterile lubricant and the catheter size of the child. And then also if we do this, we can also use local anesthesia and also 5 ml syringe and 25 gauge needle. All right, next. So for the first method, clean catch, generally for to choose which method to use, we choose if the patient is toilet trained or not. So usually in the older children that can already do toilet training, the most commonly done is clean catch because it's easier. But if they are not toilet trained, the most common technique is the transurethral catheterization, which will be explained after this. But the least common will be suprapubic aspiration. So we go into detail one by one. For clean catch, so the first thing is that if it is, we have to clean the site. So if it is a girl, like a girl, we spread the labia and then cleanse the perineum with mild soap twice or 3 times. If it is a boy, we remember to pull the foreskin. We also clean it, but we remember to pull the foreskin if they are uncircumcised. So after that, we make sure the specimen is collected midstream So that means that midway through urination, and then the child should be, if it's older child, we can ask the child to urinate in toilet, or if it is a younger one, we just put a bowl. And if the child is not toilet trained, or for example, like neonates, we can apply cold liquid. So basically in that picture is that there is a cold liquid, or maybe we can use a saline soak in gauze, so that we put on the suprapubic region, and it's called the quick wee method. All right, next. Okay, so the next method that we can do is suprapubic aspiration. This is the least common method. So it's usually commonly done in children less than 2 years old. And if we have access to ultrasound, it is better. There has okay. So basically, first, what we do is obviously we have to explain the risk and the indication and everything to the parents and get consent, and then afterwards we have to prepare. So we clean the site, and we can locally put anesthesia with lidocaine. All right, so the patient, we should put the patient in supine and frog-like position to stabilize the pelvis. All right, as seen in that the first picture. So the urethral opening, we can occlude it, because usually this will stimulate the child to urinate. So what we can do to occlude it is we can squeeze the penile urethra inwards, or we can apply urethral pressure to the meatus in girls. And then the needle site insertion is 1 to 2 centimeter above the pubic symphysis. So we have to palpate for the pubic symphysis and then locate it. And then afterwards, we insert 25 gauge or 22 gauge to 5 ml syringe. It's insert to the midline and at the needle insertion site that I said just now. And then the angle should be 10 to 20 degrees from the vertical. And you advance it under negative pressure until the urine returns. All right, next. Okay, so this is the short demo. All right, can you put the first one?
Keep them warm, but it's also very important not to contaminate this area with the blanket. So the top half, you can have your urine box sitting on your lap, and once the baby starts to pee, you collect it like this.
All right, okay. And then for the suprapubic aspiration,
The thing about clean catch is that you need to make sure that the child is you've cleaned the area, right? So most of the time is that's not the way. Nobody's gonna carry the kid and then have a box to have the box at the bottom of the or to catch the urine. Usually in the ward, clean catch. If you want to use clean catch for your urine culture sampling, is actually the least sterile one, right? So the most likely one to get contamination. But anyway, when you're doing the urinary catheterization, or if you're doing any procedure, or you're gonna get an SPA, what you usually do is you stand by a sterile container at the side, because when you open up the baby, assuming the baby is a baby lah, and baby is in diaper, when you clean the perineum, a lot of time especially if it's a boy clean catch easier. Girl, for obvious reasons, difficult, isn't it? Right. So when you clean up, sometimes what happens is that the boys will start peeing lah. So if the boys start peeing, then you quickly need to catch it. If the child is toilet trained, then you can also get a clean catch sample. But before they get the sample, that would be more of a midstream urine lah. Make sure that the mother cleans the child's perineal area first before catching, right? Because that's that method is the most likely to get contaminated. Okay, Usman, continue.
This video will discuss suprapubic bladder aspiration in children, both with and without the use of ultrasound guidance. Familiarity with this procedure is important when neither a clean catch urine sample nor a urethral catheterization specimen can be obtained. Suprapubic bladder aspiration is performed to obtain a sterile urine sample from children when the urethra cannot be adequately visualized.
324.
Who's what? 20.
Can you start at 324?
324.
Uzma, can't you like only show that video? Can't you didn't you separate the slides? I mean, didn't you separate the video? So
yeah, I did it, but I don't know what happened to the.
Using an antiseptic solution.
Open your. I mean, go back to your slides. Just transfer that video to another empty slide now. Cannot. You know what I mean?
Yeah. I did that before, but I already set the time. Yeah.
Using an antiseptic solution. You may choose to leave the diaper on during the procedure to reduce spontaneous urination. Drape the area to avoid contamination. Next, infiltrate the subcutaneous tissues approximately 1 to 2 centimeters above the pubic symphysis with 1 milliliter of lidocaine. Use the 1.5-inch needle to perform bladder aspiration. The needle should be placed at an angle that is perpendicular to the abdominal wall, which means the needle will be approximately 10 to 20 degrees from true vertical. Penetrate the skin and immediately apply negative pressure to the syringe as you advance the needle through the skin until the urine is visible. You may feel a change in resistance as the needle penetrates the bladder wall. If no urine is obtained after the initial attempt, withdraw the needle to the edge of the needle tip, but do not remove the needle from the skin. Then change the angle of needle entry so that the needle tip is more caudate. The needle should be oriented along the true vertical. Once you have collected sufficient urine in the syringe, immediately transfer the urine to a sterile container. The use of bedside ultrasonography to assess the bladder volume before you start the procedure and to guide aspiration can increase the likelihood that the procedure will be successful. The most common reason for not obtaining urine with suprapubic bladder aspiration is a lack of urine in the bladder. Ultrasonography can be used to assess bladder volume before beginning the procedure.
Next.
But it's also very important.
Next slide. Okay. All right. So now we move on to the transurethral catheter. Okay. So basically, for transurethral catheter, first we have to make sure that ensure that we have latex-free catheters if we can, because if there's children with spina bifida or any other children that require frequent catheterization, just less risk of allergies, allergy reactions. So then if we have ultrasound, that'll be great so that you will increase the success rate also. And then first, child will be restrained in the same position like this now. So it will be in supine and frog position to stabilize the pelvis. And then first, we have to clean the anterior urethra for both male and female. So we clean it with antiseptic. So yeah, and then we put the sterile lubricant jelly onto the end of the catheter. All right. So basically, for children younger than 6 months, we use five French For both those 6 months to adolescent, we use 8, and for adolescent we use 10. And then after we put the lubricant jelly onto the end of the catheter, then we pass the catheter through the urethra into the bladder, and then the urethra we straighten it by using our for the male, we try to straighten the urethra using our non-dominant hand. So for example, if you are handed, we use the left hand to hold the penis perpendicular to the lower abdomen. And then after that, we use our dominant hand, so our right hand, for example, we insert the catheter until there is a return of urine. And then once we advance the catheter, we can palpate it along the posterior aspect of the penis. And then for the female catheterization, usually we need assistance to retract the labia majora. So the process is the same as the male, like I explained just now. All right. And then yeah. Okay, next. Oh, can you press on the title of the male catheterization for the video? You just press on the
Use your non-dominant hand to hold the penis at a 90-degree angle to the patient's legs. Gently retract the foreskin if present. A physiologic phimosis is frequently present during childhood, and the foreskin should never be forced to retract. Use the non-dominant hand to hold the penis throughout the procedure. It is considered non-sterile. With your dominant hand, wash the urethral meatus 3 times using antiseptic soaked cotton swabs. At many pediatric centers, lubricant gel is placed on the catheter before the procedure is performed. At some centers, clinicians also insert lubricant into the urethra. Place the catheter in a sterile container within the sterile field between the patient's legs. The entire procedure can be done using your fingers or a forceps with your dominant hand. First, we will demonstrate the procedure when using forceps. While holding the penis in a vertical position, slowly and gently insert the tip of the catheter into the urethral meatus. Slowly advance it into the bladder. The other end of the catheter should remain in the container. You may encounter resistance near the base of the penis because of the anatomic curving of the urethra. Gently pull the penis rostrally to overcome the resistance. You may feel resistance again because of the contraction of the external bladder sphincter. You can overcome this by maintaining traction on the penis while applying gentle but continuous pressure with the catheter. Never force the catheter through the urethra, as this may cause trauma or even perforation. After the catheter has entered the bladder, urine should drain through it into the container. When urine flow has ceased, remove the catheter and...
Can you pause the video? Okay, and then the female one is on the second title.
With your thumb and the index finger of your non-dominant hand, separate the labia, which are considered to be non-sterile. With your dominant hand, use antiseptic soaked sterile swabs or povidone iodine swab sticks to wash the urethral meatus 3 times in the anterior to posterior direction. At many pediatric centers, lubricant gel is placed on the catheter before the procedure is performed. At some centers, clinicians also use 2% lidocaine jelly placed above the vagina prior to the catheterization. Place the catheter in a sterile container within the sterile field between the patient's legs. While holding the labia with your non-dominant hand, locate the meatus. If the mucosal covering of the vagina makes this difficult, gently pull the cephalad fold of the vaginal introitus downward. Once you have located the urethra, hold the lubricated catheter with the fingers of your dominant hand. Then slowly and gently insert the tip of the catheter into the meatus. Slowly advance the catheter into the bladder. The other end of the catheter should remain in the container. You should not encounter any resistance. If you do encounter resistance, do not force the catheter, since this may cause trauma or even perforation. If the catheter slips into the vagina, leave it there as a landmark, and make a second attempt to insert a catheter into the urethral meatus. After the catheter has entered the bladder, urine should drain through it into the container. When urine flow ceases, remove the catheter or both catheters if there is also one in the vagina, and submit the urine for.
All right, I'll continue. All right, so okay, so the last part is the complications. So basically, if we just do the normal method, we don't really have any complications. But if we use catheterization, it can cause trauma or microscopic hematuria. But this is not that common. The common one is mostly infection. All right, so okay, next is the suprapubic aspiration. So for suprapubic aspiration, the common complication is microscopic hematuria. The rare one is gross hematuria and abdominal wall abscess and is intestinal perforation. For intestinal perforation, we can avoid this complication by using ultrasound guidance, or we just don't perform it in children who have, example, abdominal distension or organomegaly, just to avoid the possibility of having intestinal perforation, but it's quite rare. All right, I think that's all from me. Thank you.
Okay. Okay, done already, right? Okay, if we're done, then that's it lah for the class. Okay.
Thank you, doctor.
Yeah, bye-bye.
Alright.
I'll give your marks to the office lah. Okay? Okay, bye.
Okay, thank you.
Thank you, Doctor.
Thank you, Doctor.
Thank you, doctor. Okay, bye. Thank you, doctor.